Hi, everybody. Welcome to part 2 of the C-Corp training for version 8. Turning it over to Dr. Matchison.
Okay, perfect. Okay, so we're going to jump into our favorite topic, which is going to be cardiogenic shock. That's where we're going to start. Okay, so this is going to be a clinical diagnosis where patients meet specific criteria. So it will need to be a sustained period of hypoperfusion lasting, 30 minutes or more. And the way that we determine hypoperfusion is with a systolic blood pressure less than 90 millimeters of mercury, or if available, a cardiac index less than 2.2 liters per minute. Then the second question would be, if those are met, are patients being treated either with inotropic support, usually with medications like Levophed or dopamine, or are they on mechanical support utilizing devices such as the intra-aortic balloon pump, Impella, or ECMO? So it will be either a no, they do not meet this criteria, yes, they meet this criteria at the time of the specific index procedure, or yes, but not at the time of the procedure, but within 24 hours prior. And the way that this is determined, the timing is, are they receiving these therapies at the time they enter into the operating room, but prior to the induction of anesthesia? It's also important to note that some patients do with induction of anesthesia code. So those are not the patients we're trying to capture here. So you do not code cardiogenic shock after induction of anesthesia. So a little bit more detail here. Again, the sustained period of 30 minutes or more of hypoperfusion resulting in end organ dysfunction. So systolic blood pressure less than 90, cardiac index less than 2.2. If their pressures don't meet those criteria, then what are the therapies that are being rendered to keep the blood pressure above a systolic greater than 90 or a cardiac index greater than 2.2? So are they on idotropes? Do they have an intra-aortic balloon pump in place? Do they have an Impella device, either a CP, a 2.5 or a 5.0, or are they on ECMO at that point in time? It's also important to note the intra-aortic balloon pump in and of itself does not necessarily indicate cardiogenic shock. There are other indications, class 1 indications for intra-aortic balloon pump insertion, such as incessant ventricular tachycardia or high-risk coronary anatomy, patients awaiting revascularization, critical left main disease, for example. Surgeons will often request that the interventional cardiologist place an intra-aortic balloon pump while that patient is waiting to undergo revascularization. So just because a patient has an intra-aortic balloon pump in place does not necessarily mean that that patient, he or she, is in cardiogenic shock. This slide, I think the most relevant thing here is really the third paragraph, which states that the normal range for mean arterial pressure is 70 to 110 millimeters of mercury. So normal perfusion occurs with a mean greater than 60 millimeters of mercury. So you really shouldn't be coding shock for patients without that. So don't code shock unless the mean arterial pressure is less than 60 millimeters of mercury. And this is just a diagram of how an intra-aortic balloon pump works. I don't know that this is particularly relevant for our intents and purposes. But what the balloon pump does is that, the assisted systole, the blood pressure is actually lower, so it decreases after load and facilitates cardiac output from the heart. So it's just how the intra-aortic balloon pump works. All right, moving on to resuscitation. We want to indicate or capture patients that require cardiopulmonary resuscitation before the start of the operating procedure. Again, this is a timing-sensitive designation, so you want to capture resuscitation timeframes either within 1 hour or between 1 to 24 hours. So the valid values are going to be no CPR, yes, CPR within 1 hour of the start of procedure, or yes, but between 1 and 24 hours prior to the procedure. Of note, so the Impella 5.0 does provide complete circulatory support, so that would be considered resuscitation in the same way that patients on ECMO would be considered being resuscitated at that time also. The Impella CP or the 2.5, those don't provide complete circulatory support, so those don't necessarily constitute resuscitation. So the mechanical support devices that would be the Impella 5.0 or ECMO. Cardiac arrhythmias just indicate whether the patient has a history of a cardiac rhythm disturbance prior to the induction of surgery, yes or no, and then we break that out into more detail. Was it ventricular tachycardia or ventricular fibrillation? And then again, the time frame, remote, so more than 30 days prior to the procedure, or recent, within 30 days of the procedure. Cardiac arrhythmias with atrial flutter. Again, the same time frame, greater than 30 days or less than 30 days, so more of a recent versus remote. Of note, if the patients are characterized as being in atrial fibrillation / flutter, then those patients are going to be coded as atrial fibrillation, not as atrial flutter. And then third degree heart block or complete heart block, again, the same, either none, recent, or remote. Now, typically, if it's going to be a remote designation or diagnosis, those patients will have been treated with either a pacemaker or an ICD. If it's recent, within 30 days, possibly with a pacemaker or ICD, but if it's on that hospitalization, those patients might have temporary pacer wires in place, which is a minimally invasive procedure performed in the cath lab, or they may be on medications like Isopril or dopamine, or even receive frequent atropine injections for complete heart block. And then the last here is going to be the atrial fibrillation diagnosis. Again, the same 30-day time frame. Greater than 30 days is considered a remote event. Less than 30 days is going to be recent. And then with atrial fibrillation, we're asked to kind of flesh this out in a little bit more detail and distinguish between paroxysmal and persistent events. Paroxysmal atrial fibrillation is going to be greater than 2 episodes, and it terminates spontaneously within 7 days. Persistent is going to be either episodes that last greater than 7 days or require either pharmacologic or electrical cardioversion to help treat or terminate. So it's going to be that 7-day cutoff between paroxysmal or persistent, unless a therapy is rendered, such as cardioversion or amiodarone, for example, for pharmacologic conversion of atrial fibrillation back to normal sinus rhythm. Indicate whether the patient received warfarin within 5 days before the surgery, yes, no, or unknown. Obviously, this is a significant risk for bleeding, so it's important to capture, and that's why it's relevant here. Coronary anatomy, disease unknown. By and large, all patients really should have coronary anatomy determined prior to surgery, unless it's a salvage case, for example. So there will be those rare instances, but by and large, these patients should have their coronary anatomy defined. Typically, it's going to come in the form of a cath lab report. If for whatever reason there isn't a cath lab report available, then sometimes it will be in a surgeon's note and documentation. But again, by and large, this information really should be in the chart. And then number of diseased coronary vessels. You're never going to have more than 3 diseased vessels. So the heart, the way this works is the heart's broken out into 3 major blood vessel distributions. You have the right coronary artery, which takes blood to the right side of the heart, the LAD, or the left anterior descending, which comes down the front of the heart, and then the circumflex that branches off of the left main. So the left main bifurcates, the left anterior descending comes down the front of the heart, and the circumflex goes to the lateral side of the heart. And then there are obviously branches or tributaries of each one of these. The LAD has diagonal branches, usually 2 major branches. The circumflex has obtuse marginals and then the right coronary artery breaks off into a PDA, posterior descending, and a PL branch. And then the one caveat here is there is a vessel called the ramus that comes off in a distribution right in between the circumflex and the LAD bifurcation. So the ramus can actually be considered either part of the LAD distribution or the circumflex distribution. And the way we code this is if there's disease in the ramus, then what we want to do is we want to assign that to the blood vessel distribution that gets the maximum number of vessels diseased possible. So what I mean by this is if there's disease in the ramus and there's disease in the LAD, then we would say that there is circumflex disease because of that ramus distribution, and there's LAD disease as well. So that would be 2 vessels obstructed. And in a similar way, if there's disease in the ramus again and then disease in the circumflex, with that example, we would say there's 2 vessel disease because there's disease in the circumflex, and then we would say that that ramus is in the diagonal distribution so that there's disease in the LAD distribution as well. And this is just a diagram, just a schematic of what I just discussed. So you have the left main that comes off and then branches into the circumflex, and the left anterior descending, and then you have the right coronary artery that comes off and branches off into the PDA and the PL branch vessel. Left main stenosis greater than 50% indicate if the main stenosis is greater than. So hopefully this information again will be in the chart. If it's greater than 50% stenosis, it's a yes. If it's less than or not diseased at all, then it's no. It's important here to note that the term left main equivalent does not mean left main disease. From an angiographic standpoint, from an interventional standpoint, when we say a patient has left main equivalent disease, it means that there's blood vessel blockage or stenosis at the very, very proximal portion of both the left anterior descending and the circumflex, so that you won't be able to stent that blockage unless you brought the stent back into the left main. Okay, so that's what left main equivalent disease means. So you can have left main equivalent disease and no stenosis in the left main. And then in general, when we're talking about percentage stenosis for coronary arteries, we round up. Sometimes you'll see a note or documentation that says there's a 50 to 60% stenosis. Well, what would be documented for data purposes would be a 60% stenosis. So we round those values up. Hemodynamic data. So this is looking at the ejection fraction. So how might we get this information? There are various imaging modalities utilized to obtain ejection fraction. Most common is going to be the transthoracic echo. Most patients are going to have transthoracic echoes done, within weeks prior to open heart surgery. You can also get very, very valid, probably the most accurate assessment of ejection fraction is going to be by MRI. Far less common, but very, very accurate. You can also have nuclear studies like the MUGA, but most commonly, it's going to be a transthoracic echo. You can also get ejection fraction based on a left ventriculogram. I would say that that's less accurate than the transthoracic echo. So from my standpoint, as far as accuracy of ejection fraction is concerned, I would say MRI and MUGA would be the most accurate, although probably the least common utilized. Most common and most accurate would be the transthoracic echo values. Then you can use the left ventriculogram if necessary. I would try to avoid nuclear stress test ejection fractions. Those can be inaccurate for a whole host of different reasons, depending on what patient's heart rhythm or heart rate is, for example. And then what we don't want to have to use is the transesophageal echo after the time of induction. Anesthesia is a known depressant of cardiac contractility, so it can spuriously appear that the ejection fraction is lower than it normally is if the patient has already undergone induction of anesthesia. So we try to avoid that if at all possible. As far as how this data element is captured, you can see usual range is 50 to 100%. So 50% of the blood is ejected out of the heart with each heart contraction. So hyperdynamic is greater than 70%. Normal cardiac function would be 50 to 70% ejection fraction. And then you can see there mild, moderate, and severely dysfunctional contractility. And this too often comes as a range. You can very often see ejection fraction of 60 to 65%. The way that it's reported out for us in this is that we take the average and then we round up. So for 60 to 65%, the average is 62.5%. There's no place for the decimal, so we round that up to 63% for the ejection fraction, when a range of 60 to 65% is what's given in the chart. PA pressures, are they measured? Were they reported? Yes or no? Ideally, this is going to come off of a right heart catheter. That's going to be the most accurate measurement because it's a direct measurement of right heart pressures. Ideally, it happens in the cath lab preoperatively. You can also use the right heart catheter or the Swan-Ganz catheter that's placed by anesthesia. Typically, this is placed before the induction of anesthesia. So those very initial values off of the right heart catheter that's placed by the anesthesiologist are also valid. If there is no right heart data available, then you can use the RV systolic pressure, which is obviously an indirect estimate of right-sided pressures that comes off of the transthoracic echo, but it might be the only piece of data you have if a right heart catheter is not performed. And there are some of the ranges. Abnormal values, a PA systolic of greater than 40 millimeters of mercury is considered to be abnormal. And then the means greater than 25 at rest or 30 millimeters of mercury with exercise are considered to be abnormal. All right, moving on to mitral valve regurgitation, indicate whether there's evidence of mitral valve insufficiency or regurgitation prior to the surgery. It's either a yes or a no. Again, most of these are going to come off of the transthoracic echo findings. You can also see this in the left ventriculogram. So various, etiologies, whether you're talking about mitral valve prolapse or rheumatic heart disease, or just volume overload, you can have a functional mitral regurgitation where the actual structure of the mitral valve is completely normal, but the left ventricle is just dilated and it actually pulls apart the mitral annulus, so the mitral leaflets don't coapt and you get regurgitation there. So a lot of different reasons why you can have mitral regurgitation, either chronic or acute. This is just asking whether or not it's present. And then how do we grade this? Yeah, 1, 2, 3, and 4. So trace or trivial, mild, moderate, and then severe. For these, we also want to code up. So if you have a mild to moderate mitral regurgitation documented in the transthoracic echo, you would code that as moderate mitral regurgitation here. And again, most of this data will be coming from either transthoracic or transesophageal echo. Incidence, is this the patient's first open heart surgery, first cardiovascular surgery, or is it a first, second, or third, or fourth re-op? So how many times has this patient undergone open heart surgery before? So the first operative means the patient has never had any procedure on the heart and or great vessels. So prior surgeries will include obviously CABG, anything valve replacement or repair, ASDs, VSDs. Use of cardiopulmonary bypass is not required. What would not constitute a prior cardiovascular surgery? PCIs, non-cardiac vascular surgeries, so endovascular repairs of the aorta, for example, or any peripheral vascular surgeries like FEMPOT bypass. ICD implantations, pacemakers, those types of things do not constitute a previous open heart surgery. The one caveat here that sometimes comes up is patients who have had previous transcatheter valve surgeries. So what we've done historically is that we've said that if a patient has had a previous transcatheter aortic valve replacement and now they're coming back for a surgical AVR, then that would be considered a first re-op cardiovascular surgery. And in that same way, if a patient has a previous transcatheter mitral valve replacement and now comes for a surgical mitral valve replacement or repair, that would be also considered a first re-op cardiovascular surgery. However, if they have a previous TAVR, a previous transcatheter aortic valve replacement, and now they're coming for a mitral surgery or for a CABG, then that would be considered a first cardiovascular surgery for that specific clinical instance. Yes, so moving on to status. So there's 4 different stratifications here. The first is elective, where patients can go home and they can be scheduled in subsequent days or weeks. They're stable, and there's no real significant sense of urgency with the procedure. The second is the urgent patient. These are often patients who are done. They come into the cath lab, they have their procedure performed as an outpatient, but then the interventional cardiologist or the surgeon, or in conjunction with the two, they make the decision that the patient should stay to have that surgery performed on that hospitalization. The other possibility is these patients come in through the ER with an end-STEMI, and they go to the cath lab, and multivessel coronary artery disease is identified, and those patients need to have a surgery on that hospitalization. The emergent patients are the patients that need to go to the operating room right then and there. So patients require emergent operations because they have ongoing symptoms, for example, unrelenting cardiac compromise, hemodynamic instability, whether they have medications on board or they have just chronic intractable ongoing angina, for example, or intractable heart failure. It's a patient that needs to go to the operating room without delay. And then the fourth is the emergent salvage. And these patients essentially need to go to the operating room or they will die. So they either have ongoing CPR at that moment in time, or they have an Impella 5.0 in place, or they're on ECMO. But they need to go at that moment in time without delay. So CPR is literally ongoing. And salvage is kind of one of those designations that is a little bit more difficult to achieve. These patients are essentially dead at that point in time. So yeah, a little bit wordy here, but the rule of thumb, I think, stands. So elective can wait at home, urgent can wait in the hospital, emergent can't wait, or it's not safe to wait, and then the emergent salvage literally has no pulse. And then these are the various reasons why the surgery was non-elective, or the question is, why could this patient not wait to go to the operating room? And you can see this is just kind of a list going down: acute myocardial infarction, active heart failure, infection, endocarditis, for example, either unsuccessful incomplete PCI or a cath lab misadventure. So just a whole host of different reasons why patients cannot be considered elective surgery and they need to be addressed in a more expedited fashion. Okay, moving on to perfusion strategy. I just indicate the level of either cardiopulmonary bypass or coronary perfusion that was utilized during the procedure. So 1, 2, 3, and 4. 1, no cardiopulmonary bypass or coronary perfusion was utilized. 2 is going to be a combination. So either they were not on it at the beginning of the procedure, and then they transitioned either to utilizing coronary perfusion, or utilizing cardiopulmonary bypass, or utilizing both coronary perfusion and cardiopulmonary bypass. 3 would be full cardiopulmonary bypass, so these patients are on full support for the entirety of the procedure. And then the 4th option is left heart bypass, which is a bypass conduit that pulls blood out of the left atrium and then reintroduces it somewhere in either the distal descending aorta or in the femoral arteries, and this is commonly utilized for descending thoracic aortic repairs, so thoracoabdominal aortic disease, either aneurysms or dissections. And then in a continuation of that is the question of, was it planned or unplanned? If it is a combination, So planned, the intent to treat with the combination was described beforehand. Unplanned, so the surgeon did not intend to utilize any of these options, but ended up utilizing cardiopulmonary bypass or coronary perfusion. And it was kind of an ad hoc decision made intraoperatively. Internal mammary artery use, was an IMA utilized, yes or no? And this does include the free lemas, so sometimes the lema will be taken down and reimplanted in the aorta, but that would constitute an IMA use. And then if the IMA is not utilized, we need to document why. So was there subclavian stenosis? Was there previous cardiac or thoracic surgery or thoracic trauma, for example? Previous mediastinal radiation, which we know can lead to damage to these blood vessels. It can lead to a fibrosis so that the vessel isn't usable. Was it an emergent or salvage procedure? Was there simply not enough time to take down the lema? Or was it just not necessary? Indicate whether a surgical procedure was done on any valve, so aortic, mitral, tricuspid, or the pulmonic valve. And then obviously we'll break that out into a little bit more detail, but was there any surgical procedure done on any valve, yes or no? And this is repair or replacement. So for the aortic valve, so was this a planned procedure? Was it unplanned due to a surgical complication? Or was it unplanned due to unsuspected disease or anatomy? And on occasion, we can see that. You know, I've been called to the OR on occasion to look at a transesophageal echo for aortic insufficiency that wasn't as apparent on the transthoracic echo that was performed preoperatively. And then under transesophageal echo, it becomes apparent that there's significant aortic insufficiency that needs to be addressed. Or is there a vegetation or a papillary fibroelastoma that needs to be resected on the aortic valve? So these things do happen. So the question is, was there anything performed on the aortic valve, and was it planned or unplanned? And then what was performed? Was it a replacement, repair, or reconstruction? Or was it an intervention on a surgical prosthetic valve, but the valve wasn't explanted? I would say that number 3 is going to be a very, very rare occurrence. And then breaking this out in a similar fashion for the mitral valve, either there was nothing done to the mitral valve, there was and it was planned, or it was unplanned and it was due to either because a surgical complication or because a disease or pathology was identified intraoperatively, usually with the transesophageal echo. And the same, was it a repair or replacement or some sort of a repair or intervention on a surgical prosthetic valve? Tricuspid valve, again, the same, no, yes, yes, unplanned due to a complication, or yes, unplanned due to unsuspected disease or anatomy. And the pulmonic is going to be the same. Okay, reoperation for bleeding or tamponade. Indicate whether the patient was re-explored for mediastinal bleeding with or without tamponade, either in the ICU or returning to the operating room. So in this clinical context, the ICU can be considered an OR equivalent. So patients can have their chests opened up again and re-explored at the bedside. So that would be considered a reoperation for bleeding. The location where the procedure is performed is not relevant. So it can be in the ICU or in the operating room. This does not capture patients who undergo pericardiocentesis for tamponade, which is a needle aspiration of fluid around the heart. So this is specifically talking about surgical re-exploration. And on the next slide, we talk about, so it necessitates that the patient actually leaves the operating room and then has to have something done, either in the ICU setting or leaves the operating room and then has to be brought back to the operating room. So it doesn't hold for patients who are observed for extended periods of time in the operating room. It also doesn't capture patients whose chests are left open, which can happen at times. If patients are very sick, their right ventricle might dilate to the point where surgeon can't actually fit it back into the thoracic cavity, so the chest is left open until the right ventricle recovers, and then they will go back for closure at a later date. So that's not the patient we're talking about. We're talking about specifically patients whose chests were closed, patient left the operating room, and then needed to have surgical re-exploration. Unplanned coronary artery intervention. So this is typically going to be performed in the cath lab, so a PCI or some sort of aspiration thrombectomy to open up a blood vessel, either the surgical conduit, so either the bypass graft or the native coronary. So the first question is, did this happen? Did the patient require some sort of intervention procedure in the cath lab? And then the second part of it, was it the native coronary, which is obviously the blood vessel the patient was born with? Was it the graft that the surgeon implanted, or was it on both? Deep sternal wound infections or mediastinitis, was it diagnosed either within 30 days of the operating room date or at any time during the initial hospitalization? And the answers are going to be either no, yes, within 30 days of the procedure, or yes, greater than 30 days after the procedure, but during that initial index hospitalization. So we did actually have a question about a patient who was rehospitalized on day 31 for a deep wound infection, and we had to code this no because he left the hospital and then came back beyond that 30-day threshold. So the 30-day threshold doesn't hold for patients who are still in the hospital. Neurostroke, so permanent, indicate whether the patient has postoperative stroke. So this is going to be a clinical diagnosis by and large. So it's going to be a confirmed neurologic deficit. It can either be because of obstruction, blockage essentially, cardioembolic, thromboembolic event, or bleeding. And the threshold here is 24 hours. If you have focal neurologic deficit that extends beyond 24 hours, that's a stroke. If it's less than 24 hours and resolves completely, then we call that a transient ischemic attack. So we often get questions about stroke, particularly when it comes to neuroimaging. Neuroimaging is not required or necessary to make the diagnosis of stroke. It can be confirmatory, but it is not in any way necessary. We've had occasions where we have had patients diagnosed with focal neurologic deficit, but unfortunately, they died less than 24 hours and they didn't undergo any neuroimaging. But the clinical situation was so consistent with stroke that we coded that as yes. Prolonged ventilation, indicate whether the patient had prolonged ventilation greater than 24 hours. So this is a cumulative time, and it starts from the time the patient exits the operating room. Ideally, patients are extubated very quickly after open heart surgery. Sometimes patients, for various reasons, maybe they're in acute heart failure or they have primary pulmonary pathology like COPD or emphysema, so they're on the ventilator for longer. Oftentimes we have patients who have trials of extubation, they get extubated and then they need to be reintubated because they're not able to be liberated from the ventilator at that point in time. All of those times go into calculating this greater than 24 hours. So it's any post-OR intubation time plus any additional hours following the need for reintubation if that's the case. And if cumulatively it's greater than 24 hours, then that would be considered a prolonged ventilation period. So again, just to clarify, postoperative period begins when the patient leaves the operating room. The total of 24 hours initial and then additional hours of mechanical ventilation for any re-intubation periods. However, this does not include hours of ventilation the patient requires should they need to be, for example, re-explored. If they go back for bleeding and they need to be re-intubated, it does not include that time. And then again, the time starts when the patient leaves the operating room. It's not the time when the patient was initially intubated preoperatively. Renal failure indicate whether the patient had acute renal failure or worsening renal function, resulting in either one or both of the following. I like to start with B because that's the easiest. The new requirement for dialysis, yes, renal failure. You made the diagnosis, so that's an obvious. A is a little bit more complex. So you're looking for an increase of serum creatinine levels 3 times greater than the baseline, or an increase in the creatinine greater than 4, but that acute rise must be at least greater than 0.5 milligrams per deciliter. So if a patient comes into the operating room and their creatinine is 3.7, and then postoperatively their creatinine bumps to 4.1, well, it does meet the threshold of being a creatinine greater than 4, but it was not an acute rise greater than 0.5 milligrams per deciliter. So that would actually be a no. So when we're dealing just with the specific numbers, we have to be a little bit more careful to make sure all of these different criteria are met to meet the diagnosis for renal failure. Again, if the patient has a new requirement for dialysis, then that's an obvious. And then here, indicate whether the patient has a new requirement for dialysis, yes or no. And that's any form of dialysis. So that's the CRRT, CVVHD, all of these. Again, it does not, going back to part 1 of the presentation, ultrafiltration is not dialysis, so that would not be captured here. Atrial fibrillation, indicate whether the patient experienced atrial fibrillation after OR exit that either lasts longer than 1 hour or lasts less than 1 hour but required therapy. So a lot of times we have patients who develop postoperative atrial fibrillation. We almost invariably load these patients on amiodarone and then they convert back to normal sinus rhythm. On occasion, we'll actually perform a cardioversion to get them back to normal sinus rhythm. So all of those instances would be yes. If they have atrial fibrillation going into the operating room and coming out of the operating room, then you don't capture it here, okay, because they had it preoperatively. But even if they have a history of atrial fibrillation, if they were in normal sinus rhythm, being wheeled into the operating room and then develop atrial fibrillation postoperatively, that would be a yes for this data element. And then facility identification number, and that's it.
Thank you, Dr. Matchison, so much. So thank you everyone for listening to this 2-part training on CCORP version 8. If you have questions, you can certainly email our CCORP mailbox or call our CORC hotline. Numbers are here, 213-215-2359. If you're listening to this training in November or early December, please join us for our live Q&A session, which is going to be December 17th, 2020. Time is yet to be determined, but we will get an invite. And if you have questions that you would like answered in that live Q&A, feel free to send them to this CCORP email address here so that we can get them to Dr. Matchison in advance and be prepared for that training. Thanks again, everyone.